Everyone, welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. Today's session is funded in part by the George Dick Lectureship. Today's topic of the Grand Rounds is linking late-life depression, cognitive impairment, and dementia. Dr. David Steffens is a graduate of the University of Texas Health Science Center in Houston and completed his psychiatry residency at Duke University, where he also served as chief resident. He stayed at Duke after residency as a professor of psychiatry through a variety of roles. Currently, Dr. Steffens is the chair of psychiatry at the University of Connecticut Health Center. Dr. Steffens is a geriatric psychiatrist and has over 350 peer-reviewed publications, has served in numerous leadership roles, including president of the American Association for Geriatric Psychiatry, and as an editor for the American Journal of Geriatric Psychiatry. Today's EADS codes for continuing education is 28QUEY. And so with that out of the way, please join me in welcoming Dr. David Steffens.
Thank you very much, Dr. Armstrong. Let me say first, it's a pleasure to be here. And second, let me see if, do we have the screen that we want to see? I have the thumbs up. So it's a real pleasure for me to be here, especially giving the George Dick Lectureship. I want to pay tribute to Dr. Dick. While this article is 25 years old, it was very prescient, and I would still recommend it. It covers, it says management of geriatric behavior problems, but really focuses on agitation and dementia, with really giving a nice overview of biological, psychological, and social underpinnings linking agitation and dementia, and then a very nice overview of pharmacologic and non-pharmacologic interventions for agitation. So it's a real pleasure for me and an honor to give this lecture. In terms of disclosures, support from the National Institute of Mental Health, particularly this grant that supports this work. I also received some textbook royalties from the American Psychiatric Press for the textbook, and right now I have no plans to discuss off-label uses, and hopefully I have enough synapses to remind myself that if I venture into that, to say this is an off-label use. So hopefully I've gotten all the regulatory stuff squared away here. So I hope that at the end of this, we'll have some sense of neuroimaging findings related to late life depression and cognitive decline, the role of neuroticism, which is a current focus of my research in late life depression and cognitive decline, and the role of stress and social support. So bread and butter stuff. So, you know, both depression and cognitive impairment are common problems seen among older adults in outpatient clinics and in the hospital. It's difficult to deal with clinically, and for those of us who see older adults, we often get referred patients with the question, is this depression or is this dementia? And the answer is, well, yes. And the answer, sometimes it's both depression and dementia. And that's sort of the conundrum that we face in terms of trying to sort these things out. The evidence linking depression and later dementia really starts in the late 80s, early 90s with epidemiologic studies that were ongoing at the time. The subsequent studies that followed those actually linked depression with actual incident Alzheimer's disease, and showed that a recent history of depression is associated with new onset Alzheimer's disease. In our study, this was done, the study of aging twins who were enrolled around World War II and were followed for a variety of conditions that might have a genetic influence. We applied to be part of this study in the 90s, and this involved me going out to to visit aging veterans to make diagnoses, that kind of thing. What we ended up finding is that in individuals with late life depression, the association between depression and Alzheimer's disease was there, but got less and less the more the number of years were between onset of depression and onset of AD. So you see a pretty high risk ratio when there's just 1 year difference, still significant at 2, barely significant at 3, and starting to lose significance at 4, but hovering around 2 to 3 times the risk. What this says, or at least said to us, is that there may be a prodromal state there, that for whatever reason, somebody may be exhibiting depression symptoms, but that's just the tip of a very nasty neuropsychiatric iceberg that includes dementia. So that, and looking at other clinical studies, for example, individuals with late life depression who had transient cognitive impairment in the midst of their depression frequently developed Alzheimer's disease or vascular dementia within a few years. So this notion that there's this tight linkage clinically and temporally between depression and dementia seems to hold for in both epidemiologic studies as well as clinical studies. There is a notion, though, that thinking, well, does a dose of depression sometime in your lifetime even confer a risk of later dementia? And in fact, in some epidemiologic studies, depression was a risk factor for later development of dementia, even when depression symptoms occur more than 10 years prior to the onset of dementia. So what's that about? This is not the sort of the tip of the iceberg, very late age onset depression, but this is more of a midlife depression conferring risk as well. So it's a complicated topic, and complicated topic equals you can develop a whole career around it because you'll never get all the answers. And so that's what I propose to do over the last 25, 30 years. For those of you who are really interested in this topic, just with Dr. Dick's paper that's about 25 years old, this 21-year-old paper is another one that I would recommend by Jorm in Australia, who conducted a systematic review of depression as a risk for dementia. He had looked at 7 case control studies as well as 6 prospective studies, and they both found about a doubling of the risk. What was particularly helpful is to not only see that there were these studies that sort of confirm this, but his very thoughtful discussion at the end. And he came up with 6 hypotheses, said 3 of them aren't worth really thinking about, but 3 that actually could be salient here are this notion, as we just talked about, that depression can be an early prodrome of dementia, that we're just seeing the depression symptoms first, but the dementia quickly follows, or that depression can bring forward a clinical manifestation of a dementing disease. So that let's say you have a dementia and it's in its early stages, we know that depression itself can affect your attention, your concentration, probably then your ability to really lay down new memories because you're not really paying as close attention as you can. And then that may bring out the manifestation of the dementing illness. And then interestingly, he also introduced this sort of neurobiological theory saying that depression leads to hippocampal damage through a glucocorticoid cascade. During that time, the notion, particularly in the PTSD literature, that stress is bad for the brain and that the hippocampus is particularly vulnerable, sort of gained a lot of traction. And there were some initial imaging studies in the PTSD literature. So this is more of a depression as stressor to the brain model, and thinking that glucocorticoids, if they're neurotoxic, particularly to the hippocampus, we know that back in the day, we used to do dexamethasone suppression tests, found that there were, despite our efforts to tamp down on the glucocorticoid system by giving dexamethasone, that people with melancholic type of depression, which is very common in older adults, tended to continue to have very high circulating glucocorticoids, cortisol. And so, so again, a lot of, I think some very interesting hypotheses proposed at the time for why there may be a link between depression and subsequent cognitive decline and development of dementia.
Dr. Steffens, I was hoping to make note of that paper. We're still on the intro slide, and I didn't know if that was on a subsequent slide.
You're still, I'm forwarding my slides. Are you not seeing what I'm forwarding?
We are still on the first slide.
Are you seeing other slides now?
Yes, there your slides are going.
Well, welcome to the fun of Zoom. Okay.
Yes, I'm sorry.
So, well, thank you for letting me know, because I could have given this entire talk and you all would say, why is he not showing any slides? So I appreciate it. So I'm now scrolling forward on a different slide. So, and just going through, so particularly this paper here. So I will, let's see if I can walk and chew gum at the same time. So I will forward on these. You know, the clinical reality is that about 15 to 30% of older adults do have depression symptoms. About 17, about, you know, one in 5 of non-depressed elderly have cognitive impairment short of dementia. Not much is known about the prevalence of co-occurring depression and cognitive impairment, and particularly on how they together might contribute to cognitive decline and conversion to dementia. There was one study, again, a little old, combination of impaired cognition and depression symptoms seems to double in frequency at each 5-year interval after the age of 70, such that combined depression symptoms and cognitive dysfunction were present in about a quarter of 85-year-old subjects in this particular study. Our friends in neurology who don't necessarily think about depression all the time actually got wind of all of this and started looking at depressive symptoms in their patients with mild cognitive impairment to try to understand to what extent mild cognitive impairment might increase dementia risk. And so they had 320 folks with a mild cognitive impairment at baseline, 67 of whom progressed to dementia, and those with depression and comorbid with mild cognitive impairment had twice, and that's sort of the recurring theme, about twice the risk of dementia compared to those without depression. Interestingly, this risk was the highest for the vascular dementia group. This sort of led me to join and see if I could develop a research project in an ongoing study that was only looking at depression. And I will say that ENCODE represents a weekend of me just racking my brain for a really cool acronym for a study. And so I came up with this. So I'm quite proud of it. The ENCODE study was at Duke University for over 20 years. And then when I moved to UConn, it was a combined study at both Duke and UConn. But first, speaking of Duke, so as a former Duke faculty member with seats at Cameron, 12 rows behind the Duke bench at men's basketball games, I can only say thank you. The enemy of my enemy is my friend. So I really appreciated the game last week, and congratulations to the Jayhawks. Having dispensed with that, we'll now get back to the talk. The ENCODE study included depressed patients and non-depressed controls over 60 who are willing to get an MRI, brain scan, annual cognitive testing, evaluation, and for the depressed folks, guideline-based treatment by a geropsychiatrist. So our goal was to enroll people with current depression as well as non-depressed folks, but for the depressed folks, a commitment to try to get them undepressed through standardized medication treatment, and to try to understand factors related to various outcomes, depression outcomes and cognitive outcomes. At one point, we even had an autopsy component, and that was kind of interesting as well. So we aim to compare cognitive decline and dementia in late life depression compared with the controls, and looking at the influences of MRI changes. So a baseline MRI and a 2-year MRI. Looking particularly at structural changes, white matter lesions, and hippocampal volume, looking at genetic influences, and then eventually adding the component to looking at neuroanatomical correlates. So here's a potpourri of findings. One, we found that 2-year change in white matter lesion volumes and incident dementia among depressed patients with 2 MRIs. So age, baseline MMSE, and change in white matter volumes were significantly associated with time to dementia onset. So this goes back to a long literature on what was termed vascular depression, saying that people with late life depression seem to have more of these white matter hyperintensities thought to be vascular in origin compared to their age-matched, never depressed colleagues. And so there was something about vascular depression and its worsening that actually were related to dementia onset. So that's one, I think, major finding that reinforced not only the vascular depression hypothesis, but pushed it forward and said, you know, worsening of these, quote, silent strokes is bad for you. The other thing we wanted to look at, given we were interested in dementia, and particularly Alzheimer's disease, is that over 2 years, a depressed group showed a greater reduction in left hippocampal volume. So there was already this relationship that was previously reported on dementia and hippocampal volume. This showed that the depressed group had more of a change in hippocampal volume, and it remained significant after controlling for age, sex, and baseline normalized hippocampal volume. And then we used MMSE, granted a very crude measure, but one that we gotten frequently, and basically said, if you have a big change in hippocampal volume, you are more likely to have a bigger change, that is a decrease in your MMSE, from just 2 to 2.5 years. So this was, I think, very remarkable to us, given not much of a change in time, and also how crude the MMSE measure is. It's usually thought of as a screening tool, but basically depressed patients with hippocampal volume loss were seen as having more risk of cognitive decline. So I've always liked to ground my work in what's clinically relevant. And so with this, we sort of think at a very crude level that, yes, cognitive impairment, it can lead to many things, but for these purposes, we'll say it can lead to Alzheimer's disease and to vascular dementia. The cognitive impairment might be due to both a cerebrovascular disease process and a neurodegenerative process. So we have we have both of those as potential contributors. And then we also include depression as a consequence of cerebrovascular disease, consistent with this vascular depression hypothesis, so that cerebrovascular disease can lead to depression, can lead to cognitive impairment. Those can have bad outcomes as well. And then if we just sort of bring this in on a focus with the patient with depression and cognitive impairment, that tells us that we have to understand the potential antecedents and the potential bad cognitive outcomes, so that when referred a patient and evaluating a patient with both depression and cognitive impairment, you do have to worry about, is there a vascular disease process? So you need to ask about vascular risk factors, and how well controlled, for example, somebody's hypertension is, because that could not only have trouble below the neck, at the neck, and above the neck. So those are all things to be concerned about, but also need to be worried about a neurodegenerative process that could lead to these outcomes as well. So if we now muddy the waters and throw in memory impairment, one might say, well, maybe there's a neurodegenerative process that can lead to depression and memory impairment and lead to AD as well. So we wanted to look in the ENCODE study at the consequences of memory impairment of depression. We actually had to come up with something homegrown. The literature at the time on mild cognitive impairment and all of those studies said, if you have depression, you are not welcome. And so depression was an exclusion for MCI studies, and so we couldn't necessarily use all of those criteria. So we said, well, we'll use some of them, and basically said, if there's a depression-induced or a depression-associated MCI, we will say you basically bomb out on 2 tests of memory. So by bomb out, for the neuropsychologists and other informed people in the audience, that's performance less than 1.5 standard deviations below normative values. We said on at least 2 tests of memory. And here are the ones that we had in our test battery: some wordless learning, delayed recall, some recognition memory, some paragraph recall, and non-visual immediate recall and delayed recall as well. So we said, rather crudely, if you don't do well on 2 of these tests, then we're going to put you in this MCI group. So in this study, we found 67 individuals with and without MCI depression who actually were remitted from depression a year later. So we didn't want the fact that they were still depressed to be influencing their test performance a year later. And basically, we found that even in those who were remitted from depression, there was an odds ratio. They were basically 4 times as likely to continue to meet this MCI criteria. So take-home message 1: that's a bad prognostic sign. If somebody in the midst of their depression scores poorly on a couple of tests of memory, that may persist a year later, despite them being free of depression. And that I think is that trying to get at that question was one of the main reasons I put the grant together in the first place, because as a clinician, we would like to be able to tell people, if I just, yes, you have some cognitive problems, but if I aggressively treat your depression, all of your cognitive stuff is related to your depression, will go away. Oh, if only that were the case. This was certainly not our finding, and that the fact that there's persistence there is worrisome. So we wanted to follow this up for folks who have this MCI pattern and in the midst of their depression, to see later on, do they in fact have a higher dementia risk? And we found, sadly, that over an average of 6 years of follow-up, that if you have this memory-driven or amnestic MCI during acute depression, you're sadly at risk, just like you are if you don't have depression and have this MCI, where you are at risk to develop Alzheimer's and other dementias. And so that's sad. We found 16 of 13 depressed individuals with MCI developed dementia versus 21 of 232 without. So there was still some, so MCI doesn't tell the whole story, but it certainly is a bad prognostic sign when working with an older adult and projecting out over time whether they are at risk. There were 28 cases, new cases of incident Alzheimer's disease, found that the presence of amnestic MCI, age, and ApoE genotype were predictors individually. And then when we ran a statistical model, found that amnestic MCI and older age remain significant. So that's kind of a bummer, because I like to be in the hopeful business when working with patients, but we also need to be realistic in terms of what literature tells us, what studies tell us. So the presence of memory impairment in the presentation of depression is a poor prognostic sign. And for those of you who like pictures that are worth 1,000 words, same kind of idea, that the development of that the lack of survival to being dementia free, or however you want to look at these. The red line is the people who are no longer without dementia. So all tells the same story. So getting back to our model, we can think very simplistically about cerebrovascular disease leading to depression, and particularly if the vascular disease hits the frontal lobes. And sometimes if we get MRI scans, we can see sort of periventricular, but also some involvement in those frontal lobes, then you can get what kind of looks like a vascular dementia. Or thinking simplistically, if we could think about a degenerative process that can lead to depression and memory impairment, and with that, you can the bad cognitive outcome would be more AD. So again, bringing it to the messy real world, we often will see these folks with depression and both memory impairment and executive function impairment. Again, executive function being the ability to plan, to multitask, to order things, and you see that where people, let's say with depression, will sometimes not be able to follow simple recipes or to follow a course of things if they're into doing some project, and really having trouble problem solving. And so you see both of those together, and what the concerning outcome is that you have a course that looks like a mixed AD and vascular dementia. So you see the AD, the gentle slope over time, but with the vascular dementia, the tendency to have really bad days, presumably from another vascular hit, periods of confusion that might resolve a little bit, but then the overall course is one going downhill that again is punctuated by these really bad days of confusion, like you might see in a vascular dementia as well. So I'm going to throw Dr. Armstrong a curveball and say, so this is that's the old stuff. So let me stop there and see if there are any questions so far on the relationship, on any of the neurobiological stuff, on cognitive, anything that is leaping to people's minds right now.
I haven't seen anything in the chat yet. I think most people are maybe used to saving questions for the end, and that's
as am I. But I just want to make sure,
I did have a question.
Oh yes, go ahead.
So AD changes, by which I assume one means neurofibrillary tangles and amyloid plaques, are a natural fact of aging, even if somebody doesn't go to the point of developing dementia.
Right.
So is the AD changes in and of themselves severe enough to cause dementia, or may it just be a vascular dementia superimposed on normal aging of the brain?
Right. Thank you for the question. So with the for our AD diagnoses, these were purely clinical. At the time, we did not have the resources to get PET imaging, for example, which, this is an older study. The PET imaging to really show that depression may be related to subsequent accumulation of these of plaques in particular, but with newer technology, the tangles as well. We were not able to do that. So that these were folks with clinically diagnosed dementia, broadly writ, and to the best of our ability to try to ascribe what type of dementia it was. So if it was memory driven with some executive impairment with relatively no other sort of risk factors for other types of dementias, then we clinically labeled them as Alzheimer's disease and gave it a certain age of onset. But I agree. Part of this is, I guess another way of thinking about what you asked is how much of depression is something that causes premature aging, and by premature aging, from a biological standpoint, does it increase accumulation of plaques and tangles as well? So for us, it was a progression to a clinically diagnosable dementia. There are other folks more recently have actually looked at depression and whether there are increases in plaques and tangles by PET imaging, and certainly there's evidence for the plaques, and I suspect that we'll be seeing some other studies coming out looking at tangles as well. So I appreciate the question.
Since we know that depression causes hippocampal atrophy, and hippocampal atrophy is associated with impairment in certain forms of memory, how does one distinguish those?
So exactly. I'm going to be purposely evasive. I think that the depression will, in this case, is having an effect on pulling somebody who likely has the genetics of having a risk for Alzheimer's disease, and it's hitting the hippocampus in a way that is different than through sort of a glucocorticoid cascade. So you probably have a process of neurodegeneration from the whatever causes Alzheimer's disease, but leads to plaques and tangles and hippocampal volume loss, and then boom, you come in with a glucocorticoid hit, and the poor hippocampus doesn't know what to do with itself. And the clinical manifestation, though, is one of Alzheimer's disease, or at least of mild cognitive impairment if the only cognitive domain hit is memory. I chalk this up to the wonderful messiness that is late life neuropsychiatry research, that you can have an underlying genetic predisposition towards getting a really tragic illness that affects the hippocampus, and then you can have depression. You might have a traumatic brain injury. You could have all sorts of things that can also be affecting the brain, in this case, the hippocampi, and that may then draw forth a picture that looks like Alzheimer's disease. So yeah, I mean, I find this stuff very interesting because it just brings in all sorts of clinical conditions and what we know of their underlying neurobiology, to think about then what is the clinical presentation, how do we label it, how do we think about it. So I appreciate it, and later happy to talk some more about it as well. Any other questions? So somewhere along the line, an enterprising postdoctoral fellow wanted to look at personality and depression in the ENCODE cohort, and particularly interested in neuroticism. So I wrote a grant. It got a favorable score, and then I found myself going up to Yukon. And so the kind folks at NIMH agreed to wait until I moved in 2012 for this to start. And basically, it was a grant, Neurobiology, Adverse Outcomes of Neuroticism in Late Life Depression. And again, given my penchant for wanting nice, concise acronyms, shortened it to Neurobiology of Late Life Depression, NBOLD. So old one is ENCODE at Duke, NBOLD is the one at Yukon. So I'm going to share some of the stuff that we actually put into the grant as sort of the main take-home message, is that yes, late life depression, cognitive impairment, serious public health concern. So check that box. Yes, you have to be doing research that addresses a serious public health concern. But also wanted to get across that neuroticism is a complex construct with public health significance that may benefit from a neuroscience approach. It's just been greatly understudied. So the by way of background, the neuroticism as a construct has within its several components. A level of free-floating anxiety, tendency to experience anger and related states, depression, a tendency to experience feelings of guilt, sadness, not necessarily the depression here doesn't mean having an episode of major depression, but a tendency to experience these things, shyness, social anxiety, tendency to act on impulses, and general susceptibility to stress. And so, when I wrote the grant, I said, we sometimes say when our patients are not doing what we expect them to, or their outcomes are not, well, that's because they're neurotic. And I try to be a little coy with it, which is very unusual for me to do in the writing of an NIH grant, but really to say we really do need to take this seriously, because neuroticism appears to be common. We don't know much about it. We certainly don't know much about its underpinnings, and I think they bought it for that reason, just because I don't think it's seen too much, and certainly in late life depression. So for me, the take-home messages were that neuroticism is a construct related to, but not identical to, depression. The facet of, they call it neuroticism, among all of the personality traits refers to emotional reactivity rather than a mood state. And then, basically emphasizing that the study wanted to look at the distinct contributions of neuroticism and depression to neural change and outcomes. So lifted from the grant. So 5 older adults remitted from depression, 9 non-depressed older adults completed the NEO-PI, which is a very commonly used personality inventory, and had an fMRI. We found that total neuroticism score was highly correlated with connectivity between the right ventromedial prefrontal cortex and the right hippocampus. The key things for aspiring grant writers are the words 5 and 9. I actually got a study with 14 individuals as a preliminary data, and they gave me a fair amount of money to actually look at this in a broader population. Again, I think because it was pretty novel at the time. Similarly, found functional connectivity positively associated with neuroticism in this connection between the left amygdala and the dorsal medial prefrontal cortex. So again, looking at prefrontal areas and deeper cortical areas as well. So, and then we also wanted to look at the clinical outcomes. So in over 100 patients, we looked at depression score at 3 months, and we looked at neuroticism measures that included total neuroticism, the tendency towards negative affect, and vulnerability to stress. And again, this is in a population where we were actively using medications to treat depression, and found that controlling for baseline age, sex, and age, that each of the following were associated with a higher MADRS score, that is worse outcomes at 3 months. So despite our best efforts to treat with standard antidepressants, if you had higher baseline total neuroticism, negative affectivity, and higher vulnerability to stress, you had higher depression scores at the end. So this is probably for clinicians not at all surprising. If there are personality factors, stress factors, those kind of things that are part of the picture of depression, then medications aren't necessarily going to be the end all and be all in terms of getting somebody undepressed. We also interestingly wanted to look, well, interesting to me at least, wanted to look at cognitive outcomes. And so the consortium to establish a registry for Alzheimer's disease was put together by the NIA and part of the Alzheimer's Disease Research Center Network. And they developed this battery. Because at the time, one of my collaborators was part of the Duke Alzheimer's Research Center, we grabbed that battery, we supplemented it with other measures of executive dysfunction, that kind of thing, because it's depression. But we basically wanted to look at the total score, and that we found that at 2 years, the change in CIRAD total score was connected to total neuroticism, these same measures of neuroticism, total neuroticism, negative affectivity, and vulnerability to stress, in the worrisome direction. That if you had more neuroticism in the context of your depression, you had a steeper drop in depression. I will point out that p-values of 0.2, 0.29, and 0.056 will not get you a paper, but they will get you a grant. What this says is relatively smaller sample size. If you give me funding to follow more people for a longer period of time, maybe we can make these p-values significant. So we use that to calculate power for the current study. one thing just to mention on these different things, I sort of mentioned this tendency towards negativity. The vulnerability to stress is from the NEO-PI, one of the subscales for neuroticism, and examples are, how much do you agree with the following? One of them is, when I'm under a great deal of stress, sometimes I feel I'm going to pieces. So we know people like this. We know people who don't handle stress well. I think that this particular aspect of the NEO-PI was meant to pick up on people who live lives where they are on the lookout for stressful things, feel stress intensely, and become fairly non-functional from it. And so we wanted to capture this in our study. So in this particular study in EMBOLD, again, cohorts of older adults with and without depression, with and without high neuroticism scores, you can imagine trying to put together a shoot. Let me make sure that I'm keep clicking on the wrong one, and I apologize for that. So the recruitment of people with high neuroticism scores, but who've never been depressed, is challenging, because you can imagine that people with high neuroticism scores, that's probably a lifelong trait, and for them never to get depressed is challenging. And in fact, we said in order to get a decent sample, we would have to survey about 250 people with depression or without depression to find a handful of folks with high neuroticism. So it was interesting. I interviewed these folks to make sure that they had never had a period of 2 weeks where they met major depression criteria. And these folks, had a fair amount of anxiety, a fair amount of worry, had a day where they felt sad or blue, but moved past it, and managed to live their lives, not necessarily the happiest people in the world, but it didn't appear to have the same effects that having a series of episodes of depression would have. So anxiety does exert its toll, to the extent that neuroticism picks up on chronic anxiety. It's just, again, an interesting and an understudied population. So we'll have to see what what comes out of these particular subjects with or research participants with high neuroticism, never depressed, because I think that they're different from the run-of-the-mill non-depressed controls. Again, willingness to get assessments of depression, cognition, and MRI, standardized treatment. So the same kind of models that we used in CODE, we used it in EMBOLD. So an initial paper had more subjects. Non-remitters at 1 year had higher scores in these measures, and over 3 years, time to achieve remission was associated with, so a longer time to become remitted, also with these scores. And an analysis controlling for baseline cognitive score, age, sex, and education, vulnerability to stress was associated with baseline to 2-year change in cognition. So among the depressed folks, vulnerability to stress, higher vulnerability to stress, was a bad prognostic sign when it came not only to mood, but to cognitive outcomes as well. Effects of neuroticism on acute treatment. We published this fairly early on. We were still recruiting, but we're excited about the data. So we published it, looking at folks we offered initially sertraline. 9 others were switched to antidepressants. MADRS was the outcome score, and both total neuroticism and vulnerability to stress were predictor variables. and those who failed to achieve remission had higher scores on both total neuroticism and vulnerabilities to stress. And there's an example of one of them there. So COVID hits us in late March, early April. We start seeing cases in Connecticut, and that pretty well shut my research life down. So I decided to write the renewal of an NBOLD grant looking at stress, because that seemed to be the smart thing to do, and to study effects of stressors and neuroticism on mood and cognitive outcomes, to look at the effects of stress and neuroticism on brain structure, and then to put these together in multivariable models. Very messy design here, but pretty much everything that I can think of that would be useful to think about broadly when looking at late life depression, stress, neuroticism, brain changes. You get the vascular changes leading to late life depression, acute and chronic stress is in there, neuroticism and low resilience affect things, functional MRI changes, clinically sort of looking at attentional responses, remission, and relapse related to then cognitive decline and dementia, and then also looking at things on the positive side that might buffer some of these stress effects. So a very busy picture. I thought I would share it just because it took me forever to put it together. So I want to make sure I put it to good use in talks like this. So, stress, what do we mean by stress? Why would we even want to look at it, since it's a sort of amorphous blob? We sort of know it when we experience it, but how do you measure it? Why would you put it in a grant and make a grant very stress-centric? We thought that the initial NBOLD cohort did focus on effects of neuroticism, but we did include several stress measures given the relationship between neuroticism and stress. And from our preliminary data, stress measures appeared to exert important effects on key longitudinal outcomes. So, so we're augmenting our standard battery that included the ACEs, which is certainly my first foray into getting at adverse childhood experiences, with adding in this time the perceived stress scale and a homegrown epidemic pandemic impacts inventory for pandemic related stress. And so we're trying to get basically a life stress perspective on how that affects depression outcomes. So relatively new data, one following 98 NBOLD subjects who completed these measures, treated with standard antidepressants, evaluated at least quarterly. After 4 years of follow-up, 84 were determined to be cognitively normal and 14 were assigned diagnoses of cognitive impairment or dementia. Given the smaller group, for purposes of analysis in order to get the grant, we sort of combined the cognitive impairment and dementia groups. A very busy slide, I apologize, but looking at the effects of changes in a variety of predictors, stress-related or personality on cognitive outcome using logistic regression, and looking at number of stressors, conscientiousness. You see the p-values here. Again, this is to help justify a grant, but it looked like counting the number of stressors and some measures of personality were in fact related to cognitive change. And you can see we controlled for a variety of factors as well. So so this was used to justify getting the grant that just started recently. We looked at the synergistic effect of change in neuroticism and in number of stressors, so that you have sort of a probably a lifelong characteristic in terms of tendency towards neuroticism, as well as looking at the number of stressors. And we found, again, for these preliminary data, that the interaction effect was just barely significant, saying that more increased stress was associated with an increased likelihood of cognitive impairment or dementia among those who had a lower 2-year decrease in neuroticism. So one thing that we found was that treatment of depression tended to also, when we got rechecked neuroticism, in some respects, when you're not depressed, your report of neuroticism changes, which is interesting because we think about personality being fairly fixed. But in the context of a depression, which is when we first get these folks, they can report higher. For those who don't experience that much of a decrease in neuroticism, and if they have more stressors, there's something linking these two that is having a negative effect on cognitive change over time. So this was kind of, okay, how do we get our head around all of this stuff? We know stress is bad, neuroticism is bad, in addition to everything else we know about neurobiology, and put all of this into the grant proposal. And it hit. So that's good, and we'll be able to look at this more meaningfully in a much larger group going forward. The last couple of slides here are, looking at COVID-related stress. During the pandemic, we did a sort of this telehealth study and employed this EPG, which I'll talk about in a second. Completed surveys in 40 individuals, in 31 who were in remission prior to COVID in Connecticut. 7 became symptomatic, 4 relapses during the COVID pandemic based on scores of the brief Carroll. Themes that emerged from the EPG were concerns for family, financial, concerns for themselves, especially if they had comorbid medical conditions that put them at risk for poor COVID-related outcomes should they contract COVID. So really the study showing that some previously remitted individuals are at risk for recurrence. And I worked with a UConn medical student, Tia Kozar, last summer. Again, so our child psychiatry group came up with this epidemic pandemic impacts inventory, and then our geriatric research group adapted it for older adults and named it the EPG. And if folks are interested, it is, I don't know if it is, I think it's in the process of being published by our child group, and I can certainly, if people want to email me, I can get that to them. But over the past year of the pandemic, we did see mild increases in depression in older adults with a history of depression and the controls. And that change was related to changes in home life, social activities, and finances that they said were related to COVID. Interestingly, we also found pre-COVID to COVID increase in resilience as measured by the brief resilience scale. So, you know, people sort of, I think, have assumed that older adults are just going to get blown away by this, by the pandemic and the isolation, and some are, but you know, this is a cohort that has lived through, in some cases, world wars, certainly other wars, Vietnam, Korea, the more recent wars, recessions. Many of them grew up children of the Great Depression. So, you know, some of them are not easily rattled, let's put it that way, by stress, and that they have developed a toolbox, I think, that has had a fair amount of components of resilience in it. And so it was interesting to us to see this reported increase in resilience, despite an overall mild increase in depression, in both of our groups as well. So we're looking forward to looking at that more closely as well. This was sort of a summer project, and so we're wanting to look at this more carefully as well. So next to final slide. I hope we've been able to review some of the literature in the finding depression increases the risk of cognitive decline and dementia. That depression, again, may be tip of a bad iceberg, prodrome of dementia. Some older adults can progress to Alzheimer's, other to vascular dementia. A documented memory impairment in the context of depression is a bad prognostic sign. And neuroticism may accompany late life depression, may affect mood and cognitive outcomes. And finally, stress can accelerate cognitive decline in the context of late life depression. So I really appreciate the invitation again. I have two screens, and it turns out that Zoom is challenging. So I appreciate you letting me display my executive dysfunction in trying to make sure that I'm forwarding the proper slides. And I really appreciate your attention. I will stop sharing so that, not necessarily so that you can see my smiling face, but hopefully I can see some of yours, and I welcome questions.
I had a couple sort of statistical questions.
Oh my, okay.
And one is that depression is common, and dementia, particularly at certain ages, is common, both Alzheimer's dementia and vascular dementia. So are these simply two common diseases that happen to be co-occurring, or is there, I may have missed there, is there actually an elevated risk above and beyond?
So, so that's what I've been trying to answer for the last 25 years. I think that it's both. I think that there, from what I can see, if you have a fairly serious late life depression with either minor depression or no history of depression, but you're now at the age of potential onset of Alzheimer's disease, if you have depression, particularly in the context of memory impairment, I think you already have a neurodegenerative process cooking along, and that for whatever reason, it's presenting initially with depression symptoms. I think that there are folks who have had either childhood, early adulthood, middle onset depression with occasional recurrences, and for that I'll embrace the depression as stress model. For each of those, it's not good for your brain, and that for that reason there appears to be it confers a certain risk in terms of dementia. If that is more of a vascular dementia, there certainly is this long-standing sort of bidirectional relationship between cardiovascular disease and depression. So there is no reason in my mind why there isn't a bidirectional relationship between cerebrovascular disease and depression as well, and that in itself might create a more of a picture of vascular dementia. The vascular piece is also interesting for Alzheimer's. I think that now much of the Alzheimer's literature and things that we can do to prevent Alzheimer's disease, a lot of it is practicing good health habits that basically decrease your vascular risk from control of blood pressure, diabetes, being careful what you eat and what you drink. I think in some cases it's just the first manifestation, and I think for others there appears to be from an epi-stats standpoint conveyance of risk but risks that we can understand, I think, more through a vascular lens.
I've heard it said that like all these neurocognitive patients should be on antidepressant. And do you see, I mean, that might be an oversimplification, but these patients with depression, whether it's contributing, comorbid, or maybe just as a symptom, do you see any difference in how they respond to antidepressant treatment?
So, yes, the more depression, the more likely they are to respond. And there's certainly studies out there that would back that up, that if you have major depression in the context of a dementia, then you are more likely to respond. CTAD, citalopram, and AD study, for example. For those with minor depression or subsyndromal depression, it doesn't appear that antidepressants do much, because there wasn't much depression to start with. And so from a statistical standpoint, you might see a little bit of improvement, but it might not be statistically significant. But if you see major depression in the context at any time, then antidepressants, I think can play a role. I think the other part of the question might be also, so if you have major depression and mild cognitive impairment, do you start throwing cholinesterase inhibitors at this group? And that's basically the next question. It would be really nice if we had more definitive treatments for Alzheimer's disease. But I think it's clear that if you have depression and amnestic mild cognitive impairment, I worry that there are lots of plaques and tangles already brewing, and therefore this is an opportunity then to treat. And a lot of people, I think clinically, a lot of people do treat with cholinesterase inhibitors in addition to antidepressants when depression and mild cognitive impairment are comorbid. It's tough to sort out. You're giving people two medications that will upset your tummy and not make people really like you very much because of that. And it's challenging from a pharmacologic standpoint. It may be that also because of both the depression and some Alzheimer's or other dementia, that they have frontal executive dysfunction, and that they may be good candidates for problem-solving therapy, which has certainly taken hold for non-dementia major depression in the elderly. It's basically the therapist is a coach that lends their frontal lobe to the patient to help them solve problems that they think are related to development of their depression. And by helping them problem solve and seeing how they can do that, that hopefully then generalizes to other things that they can do to help their depression as well. So it's also very well tolerated and accepted by older adults because it's focusing on here and now, not my relationship with my mother 70 years ago, that kind of stuff, which may have a role, but in this case, the problem-solving therapy can be helpful. I see the question on apathy as well came through, popped up and then went away from the chat. But so yeah, apathy is another grant that I just got funded, is looking at sort of apathy and how apathy circuits may differ between late life depression and early Alzheimer's. Apathy as a target is challenging. I think a lot of folks have, for some, antidepressants may relieve it. In my experience, not always, and people will still be left with a sort of an apathetic, amotivated state with just an antidepressant. 20 years ago, I would throw in bupropion as an adjunct, thinking that dopaminergic circuitry, tickling that might also be helpful. And in treating apathy and lack of motivation and frankly lack of energy that sometimes we can see to some degree. I think nowadays a lot of people will use SNRIs and get the effects again in the context of depression. So this is on label, but basically saying that if we can get the noradrenergic piece up a little bit, that may help the apathy. Questions always arise, off-label, of course, about methylphenidate and other stimulants, and I will plead guilty to having some success in that regard. I've used pramipexole, off-label, as well as a dopamine type agonist with some success to treat apathy. There are ongoing studies looking at L-Dopa off-label Dr. Austin's proud of me every time I say off-label because that's and so this is I think an unsettled area. It's certainly something that brings in not only our experience of depressed people, but everything we know about vascular disease, because certainly people post-stroke, apathy, very common. And if you have people with these silent strokes and you're seeing depression, there's no reason why you can't also see apathy, other domains sort of cognition, as well as motoric. So you can see, kind of a vascular Parkinson's. And so oftentimes you'll see these older folks with mask-like faces, difficulty initiating movement, and it's all part of a vascular picture as well.
Dr. Byerly is in the room and he's got his hand up. Dr. Byerly.
Oh, hello, Dr. Steffens. Thank you so much for your wonderful presentation. I've been a schizophrenia researcher primarily throughout my career as mostly an effectiveness researcher. And I'm sorry if I missed it. I jumped on about 10 minutes into your talk. I was wondering if you might share, if you hadn't already, what the portion of your grants might be looking like recently that describe your long-term goals or intermediate goals. And thinking in particular, I bet our clinicians are wondering how this fits into ultimate clinical considerations and treatments at future steps.
Got it. Well, thank you. And applaud the work you were doing in schizophrenia as well. So, it's way back at the dawn of time when I was a resident, I started one of my first rotations was on an affective disorders unit, and saw all these older adults come in very, very sick, late onset depression. Some of them got sort of this complex polypharmacy, some of them got ECT, and they got better. And then 4 years later, when I joined faculty, I was assigned to that unit, and I saw these same folks coming back, only now with some cognitive impairment or dementia. So for me, this was great in that it enabled me to submit research grants in an area that I found to be very clinically relevant at the time. It took me, 12 to 15 years to actually start getting some answers. So that's you have to be into delayed gratification from that standpoint, as I'm sure you know, that the research process, particularly clinical research, can be kind of painstaking. But I had a sense in talking to my mentors that this was an area to pursue, and I fortunately had good mentorship and support along the way. NIH has career development awards for young researchers who have mentors, and so there is a process and way to do this and to see a career going forward. I'm not sure if that gets at your question, but for me, this fit in early on with what I wanted to do with my career. I didn't know it going into training at all, but right place at the right time with some interesting research going on that I was able to join. Other questions?
How much comorbidity, medical illness wise, was there? Depression oftentimes, has comorbidities, smoking, being overweight, metabolic syndrome, things of that nature that could, of course, lead to certainly vascular dementia. And so how do you parse that out?
Yeah, that's a great question, because I think that's it's part of the messiness that is late life depression, because it's dealing with a population that, because they're depressed, they are more likely to have more medical comorbidities. So we've used the cumulative illness rating scale geriatric version to try to quantify the medical burden. We also asked specifically about a lot of medical conditions, particularly those that might convey vascular risk as well. And in many of our studies have used that as a covariate because it is important. A lot of these, as you mentioned, confer vascular risk. And so to the extent that you have either actual strokes or these smaller silent strokes that accumulate and cause depressive symptoms, I think it's important. And for us, I think on average, folks had several comorbid medical conditions. When we actually looked at vascular, the construct of whether somebody met criteria for vascular depression, we looked at a variety of clinical and depression symptoms, but the one thing that was very powerful was history of hypertension. So thinking about, because we were, I think, very much gung-ho in the 90s and 2000s about, vascular depression should be its own subtype of depression and da-da-da-da-da-da-da. And I think we've sort of gotten off that bandwagon, although most of us say, yes, it is. But it's interesting that potentially one of the things that we would advocate for in DSM, whatever, 6-7, one of the required elements might be history of hypertension. So it's we have to sort of look at what is present in the lives of older adults, and many of them have medical comorbidities. A lot of them are starting to experience functional impairment. Psychologically, they're experiencing losses and loss of social connections as well. So I think all of this somehow needs to be taken into account. It's challenging because that just makes the number of variables that you have to look at just almost insurmountable when it comes to actually, so what kind of sample size do I need to take all of this into account? But we try.
This is George Dick, and I want to thank you, Dr. Steffens, for your presentation and for your work in trying to understand dementia better. And we, of course, hope that all this will facilitate our search for better treatments. So we're still on that path all these years.
I appreciate it, and I appreciate your understanding. I've neglected to say, I was supposed to do this in the fall, and somehow this made it to my Wednesday schedule and not Tuesday. And I agree, I appreciate you allowing me, Dr. Dick, to follow up with you and we're very gracious in understanding my my fumbling the last time. So it's good to meet you virtually, and thank you for your contributions as well.
Okay, sorry, my video doesn't seem to be working, so you can't observe me.
It's all right. If anybody has any follow-up questions, if any of the residents have any questions for me about how great geriatric psychiatry is as a field, or anything that I've talked about today, I would love to hear from you. There are opportunities in the I'll just sort of plug this, American Association for Geriatric Psychiatry for residents who think they might be interested in pursuing geriatric psychiatry as a field. And there's all expense paid if you're interested and want to apply to a scholars program. We meet in March, always in wonderful places to be at March. We were in COVID spreader Orlando this year. Hopefully we'll be in non-COVID spreader New Orleans next year. This is, I think, a very exciting field, a much needed field. Dr. Armstrong and I were talking about how undersubscribed all of our fellowships are, but certainly is the case in geriatrics. I think it's an exciting population to work with and very gratifying. So happy to take any follow-up contacts from trainees and students and faculty as well.
Well, thank you so much. Yeah, everybody, if you want to ask further questions, either myself or Rhonda can facilitate with emails. And we appreciate your time, Dr. Steffens, and for your presentation today.
I appreciate it. Good to see you, and thanks again.
Bye-bye.